Yes, Bali sir.
Thank you, sir. Thank you so much. At the outset, I want to thank the entire team of ISM SICS and AIOS for giving me this opportunity to talk to you about the economics of SICS. And I do not have any conflict of interest to declare, no financial disclosures to be made. This sounds like a presentation which is trying to sell refrigerators to the Eskimos. All of us already know, the economics of SICS, and we are not really going to gain too much by trying to convert the people who are already here. But we still have a talk on this. So the question that arises is why, right? So to answer that, I'll just go through 2 or 3 important statistics. Cataract extraction is one of the most common surgeries performed worldwide. The policymakers are interested in knowing the most cost-effective way of employing the resources. And there is very little data that is published on healthcare economics aspects of manual small incision cataract surgery. Now, we did a survey, and which is yet unpublished, and we've come across this, that 75% of Indian ophthalmologists are practicing phacoemulsification, but 83% are practicing manual small incision cataract surgery. So if you look at those data points, we have around 17,000 data points. And the data, and everybody sitting here has data which is available to him. He does not need to go out and reach out to any institution. He can use his own data to get published, does not require any ethical approvals for it, and is not dependent on any of the institutions. We have Dr. Gogate, and we have some luminaries here who worked in this field, and they are making their services available. We have the IJO special issue coming up on this. And the purpose of this talk is to exhort everybody to use their data and publish it. And that is what we're trying to do is, what we'll try to do is we'll just sensitize you to it, and we'll help you reach out to people. We'll give you some templates, and you build it up from those templates, right? So the first thing is, whenever a new procedure comes in, first thing we do is we do the outcomes. What we'll do is, what is visual improvement, astigmatism, complication rate, that's the outcome description right on top. Can I have a pointer? Okay, so the first, okay, so first thing we do is outcome descriptions. That has already been done. Then the cost descriptions.
You can use the cursor if you want.
Okay, yeah, I think that's much better. Okay, so first thing is the outcome descriptions. Then we have cost descriptions. Kitna kharcha aayega uske upar. Then we link the cost to the outcomes. And then we do some sort of a cost analysis. Now these steps have been done. And then we do a full economic evaluation. When we do full economic evaluation, there'll be many terms that will be thrown at you. If effectiveness of 2 techniques is absolutely same, right? Then the one which is cheaper, that is cost minimization, which is cheaper is definitely better. And at the other end of the spectrum is cost benefit analysis. Now what the policymaker wants to know is, he will say that convert all your benefits into monetary terms, and then give us cost is a monetary term, and then the benefits are monetary. We are not very happy doing that, because there are a lot of assumptions which are there, which would be coming in, and we don't really want to make so many assumptions. So we want to use some of these techniques in between, which is cost effectiveness and cost utility analysis. And one is, of course, mortality, morbidity indicators, but then the question that arises is, what are we going to use in small incision cataract surgery? I'll come to that later. Cost utility analysis measures it in quality of life years adjusted, and DALY and QALY, right? Now, why we're talking about it today is because a very famous study called FEMCAT has just recently, it was a French multi-center participant masked randomized superiority cost effectiveness trial, which compared femtolaser with phacoemulsification, and it said that FLACS, that's femtolaser assisted cataract surgery, was not, when you use femtolaser, you have to spend 10,700 euros for every patient extra, for every patient to get the same result which you can get with phacoemulsification. So that is something called incremental cost effectiveness ratio. That is the cost difference to the effectiveness difference. This is part of the full utilization analysis, and what we have done is, so now the question arises is, what are the endpoints that we can use? Sir, I'll take just 1 minute, right? So we can use costing analysis, we've already, all right, so what are the endpoints we can use? It is, the complications at the end of third month, best corrected visual acuity 6669, absolute manifest refractive error which is left of say less than half a diopter or whatever we can decide, and post-operative astigmatism of less than half or 1 diopter. And complications, we've got a list of complications which you can see from here, which can be utilized. Costing analysis, there is a list, you get a check, there is a checklist, and you fill in the data from that checklist, and that gives you a complete costing analysis. Broadly, costs are of capital, labor, material, and operational costs. So depending on the data which you have in your practice, you add all of it. And then there are these studies, most famous one being this study from India which compared $15 for small incision to $42 for phacoemulsification. And in Thailand, there's this incremental cost effectiveness analysis which has come $62 to $104. And these are the different methods of evaluating it which are available. So what I will request all of you to do is reach out to your local ISMSICS chapters. And Sir is here, Dr. Boramani is here, Dr. Sahu is here. And what we'll do is we'll put out these templates, and you can utilize the templates. You see, all these data points are with you. You have your costs. You have your clinical outcomes. And this is data which is of immense value for policymakers. So the decision to go forwards lies with all of us here. I hope, if we manage to bring out even 40, 50 papers out of this, I'll really be happy. Thank you so much.
We'll take your suggestion.